Good morning, ladies and gentlemen. Thank you for coming to this morning myeloma forum talk. Now, I choose this topic on the myeloma bone disease is because the bone disease has a very great impact on the quality of life for myeloma patients. And along with this, with a modern investigation for bone disease and this and that, the concept of diagnosing myeloma has changed over the times. And so I'm going into a bit of detail now, starting from the more basic information first. Now, myeloma is a disease of the immune system cells called plasma cells, which turn cancerous. From this slide, you can see in our immune system, all the cells develop from the stem cells, and the stem cells develop into lymphoid cells and myeloid cells. And the lymphoid cells consist of lymphocytes, which we can test in the blood. And the lymphocytes, there are different types. There are B cells, T cells, and NK cells. And when the B cells become exposed to various antigens in the lymph nodes, they develop into a plasma cell, which is the antibody-secreting cells. Now, this is a plasma cell making antibodies. The function of the antibodies is to coat and attack the bacteria and causing a punch holes on the bacterial wall and lead to the death of the bacteria. And also, when a bacteria is coated by this antibody, they are being eaten up by the other white cell more easily. So this is a function of the normal plasma cell, that's to make the antibodies. Now, this slide shows in normal people, for every one of us, bone marrow is not a static organ, not a static structure. There's always a remodeling process going on, and the remodeling process is being process is carried out by two sort of cells. One of them is the osteoclast, and the other one is the osteoblast. Now, the osteoclast shown here is the red one, the large red one with many nucleus inside. They create a kind of slightly acidic environment which dissolves the bone. And after this happens, the osteoblast is the cell that lay down a kind of matrix in the bone, in the holes there, and then this matrix becomes calcified. And eventually, this osteoblast becomes embedded in the calcified tissue, which is a new bone. So this process of breaking down the bone and laying down new bones is going on all the time. Now, this picture on the right, on the top there, shows normal bone marrow. We have very few plasma cells here, and these are the plasma cells, just few of them, very few of them, okay? Just a few percent in the bone marrow in normal circumstances, in normal people. And what happened is, if there's some genetic changes in the plasma cells, they become transformed into a malignant plasma cell, which is producing one clone of abnormal antibodies. So the diagram below there show in a lot of elderly people, although there's some genetic changes, the plasma cell number is very low, and they secrete low amount of abnormal this antibody. At that stage, we call it MGUS, which is a monoclonal gammopathy of unknown significance. But every year, a few percent of these will progress to become myeloma. And some of them go through another stage called asymptomatic myeloma or smoldering myeloma. For patients with smoldering myeloma, there's a higher chance of developing into multiple myeloma. Now, what happened when somebody's patient developed, what happened to myeloma patients what happened to the bone in the myeloma patient? On the small picture on the right side, you can see there's a small area where there's accumulation of these plasma cells. And because this sort of focus occur in many places, we call this disease multiple myeloma. Multiple means many area. So in this small environment there's abnormal myeloma cells interact with the osteoclast, which is the cell that break down the bone, dissolve the bone. So there's an interaction between each other. The osteoclast enhance the growth of the abnormal plasma cells. The plasma cells secreting some chemicals that enhance the growth of the osteoclast on the other hand, as well as inhibiting the osteoblasts. So in this synergistic way, they kind of quietly chew away the bone. As a result of this, patient will experience bone pain. When the bones, a lot of these bones are affected, the bones weaken, so their bone is quite osteoporosis, a bit like osteoporosis. And the typical feature is, if it's very focused, then you've got a punch-out lesion on the bone, which is in hematology, radiological term, we call it a lytic lesion. Now these are all the X-rays pictures of the lytic lesion. On the skull X-ray, you can see some of these are holes-like, more loosened area, and they are quite round, and they are typical for osteolytic lesion. And there's another one on the bottom there, which is on the femur, and there are lytic lesion there. The one on the with the right R there, you can see the bone is, there are a lot of osteolytic lesion almost joining together. Along with that, the bone becomes very osteoporosis. So this is another picture show the right humerus, which is the bone here. And there are so many lytic lesions until eventually the bone's becoming very weak and fracture on the right side there. You can see it on the X-ray. Again, pathological fracture of the femur. This sort of fracture occur, we call it pathological fracture because it's as opposed to traumatic fracture. Pathological fracture without trauma, it can occur on minimum exertion, minimum movement, and sometimes for no reason. Of course, trauma can also lead to fractures of this bone easily. This also typical area that can be affected by multiple myeloma is our vertebral bodies. And you can see on the small picture over there are multiple areas in the vertebral body which is affected. And when fracture occur, there may be cracks there, but the vertebral height is preserved. And after a while, this fracture area, they collapse. And you get a compression fracture. Sometimes they can be wedge-shaped like that. As on the X-ray picture, you can see also the vertebral body become a wedge-shaped like that. The problem with a wedge-shaped vertebral body is that the posture will become affected. The patient will stoop, the stomach become protruded, the height will reduce, and of course, there will be a lot of pain. Now, the picture below that shows what we saw many, many years ago when I was in my training years in the 90s. A lot of myeloma patients end up on a wheelchair, pain everywhere, and we are used to prescribe morphine or sort of strong painkiller, which nowadays we have a lot lesser now compared to years ago. So the problem with bone disease is causing, as I mentioned, a lot of pain, which can be acute or chronic, and lead to a lot of use of the morphine type of medication to control the pain. The patient's mobility is much reduced, And the mechanical effect is, as I mentioned, loss of height and deformity, reduced pulmonary function if it's in the vertebral column in the thorax got affected. The lung cannot expand so well, lung function reduced, kyphosis, protuberance of the abdomen. Kyphosis means the bend back. And some situation also spinal cord compression. And a patient who has got this skeletal problem before, the prognosis actually has a negative impact on the prognosis. Of course, with all this pain, all this abnormal reduced mobility, loss of dependence, pain affecting sleep, patient may be depressed, all these contribute to the compromised quality of life. Of course, treating fracture incur cost as well. Now I'll come back to this picture. Traditionally, I showed this picture earlier on. There's in a lot of more senior citizens, they may have a small clone of this abnormal plasma cell producing the antibodies, abnormal antibodies, and eventually they develop into different stage and become multiple myeloma. So to diagnose multiple myeloma, really the requirement is to demonstrate there are abnormal plasma cells in the bone marrow. We want to demonstrate the presence of this abnormal antibody and look for any damage that this disease is causing, like the bone, the kidneys, the blood test. Yeah, so this become the diagnostic criteria. And the bone lytic lesion has always been an important diagnostic criteria. And so anybody who has got this sort of typical lytic lesion, they become multiple myeloma. In patient who has got the smoldering multiple myeloma, the SMM, although they're producing a lot of antibodies, their bone marrow has a lot of plasma cell, but they're not causing any organ damage like the lytic lesion, kidney failure, or this. We classify them as smoldering multiple myeloma. And because some of these patients can stay for months and years and do not require any treatment, our policy normally is to just monitor very closely. The problem with this approach is we are waiting for some adverse event to occur, and by the time adverse event occur, what's the point? Some damage already been done. That's why the concept is now, we have now various radiological investigations which can kind of more likely to pick up some lytic lesion, some information that lead us for early intervention for this group of smoldering myeloma. Similarly, for patient who is in MGUS stage, which normally we just do blood test, monitor only, the X-ray exclude all lytic lesions. But now we have more modern radiological technique to demonstrate whether they are really abnormal lytic lesion, they are not. So the traditional X-ray, can often miss out any lytic lesion, but with newer radiological technique, we can pick up some. So a lot of MGUS patients, they may have additional lytic lesion than we realize. And whereas smoldering myeloma patient, if we demonstrate certain lytic lesion, we want to take action earlier rather than wait and monitor until organ damage occur. And CT scan is one of such technique. Now on this picture, you can see on the L4 lumbar vertebra, there's some signal change within the vertebral body, as well as in addition, you can see there's erosion at the bottom of this vertebral body. That's also causing some compression fractures. You see that the vertebral body is a bit wedge-shaped now. And another CT scan, this shows there's an arrow there, at the arrow there on the iliac bone. There's a lytic lesion on the picture A there. Picture B was the cross-sectional scan, again show a lytic lesion. So CT scan can show lytic lesions. Now, things have moved forward. In some countries or in some European guidelines, already they are recommending using the CT scan instead of the traditional X-ray to demonstrate this lytic lesion. There's some advantage is very sensitive and high detection rate, and the radiation dose is actually very small. This is not an ordinary CT scan. This is a whole body low dose CT scan. Another technique that's being used now is MRI scan. It's not so good at picking up the lytic lesion, but it can demonstrate what's going on in the bone marrow itself. If the plasma cells infiltrating the bone marrow, it will show signal changes. And quite often also, the plasma cell form a lump like that. The accumulation of this plasma cell form a lump. We call this plasmacytoma. And MRI scan is good at picking up this. In some patients, they present just with plasmacytoma alone, and we call them solitary plasmacytoma. And the role of this modern scanning, MRI or PET scan, is to ensure that this is really a truly solitary one. If there are multiple, this sort of lump of this plasma cell, then they really qualify to be called multiple myeloma. The picture on the right side shows infiltration by plasma cell causing quite extensive damage to the vertebral body. Already the back is already kyphosis. And another scan shows infiltration of the bone marrow, signal changes. And one other scanning technique I want to mention is the PET scan. Nowadays, a lot of cancer, doctor treating cancer will order PET scan to locate where the tumors are. Similarly, it's now being used in many places to demonstrate where are the disease. The problem you see on the right side is it can demonstrate there are lumps places lighting up, but exact location you do not know. Can you tell on this picture, the front, the back, still some limitation, but nowadays all this digital data on the scanning, they generate digital data. You can actually extract the data and combine them with CT scan, and with that, then you can more exactly locate where these myeloma deposits are. So you can combine them both together. And so initially there's a PET scan show picture on the left side here. And later on, people are able to combine PET scan and CT scan, merge the data together. But now the latest development is the CT scan and PET scan at one go, they do both together. So there's no when you do the PET scan, your posture is like that. When you do the CT scan, your posture is like this. And you want to combine the information so they do not really align. And the latest one is you just lie there, PET scan and CT scan together at one go. So it will give you an exact location where the myeloma deposits are. You can see on the pictures. I'll show you the other side. I think there's a lot of information that we skip that for the time being. So how about the treatment side? Now the treatment for myeloma bone disease will involve many different teams. One doctor alone cannot possibly deal with so many problems, all right? Normally, myeloma is treated by hematologists, which tend to be the main doctor, and some oncologists also treat multiple myeloma with chemotherapy, calcium bisphosphonates denosumab to strengthen the bone. And we also need help from the pain team. There are specialist doctors in the hospital that deal with pain control. And we have a lot of involvement by the orthopedic surgeon. And they are orthopedic surgeons who have become specialized in dealing with bone cancer involving the bone. They won't deal with just fracture due to trauma, this and that. They specialize in dealing with bone metastasis spread to the cancer and treating them. And they have their own scoring system to see which patient will benefit from surgery, what are the risks, and whether they recommend to go ahead with surgery or not. So they have own scoring system. But from our point of view, from hematologists, primary doctor, or oncologist, we have to look to see which patient is suitable for referral to the orthopedics. And quite often, I go back to that later. And there are also rehabilitation involving physiotherapy, occupational therapy, and radiation oncology may also involve in treating myeloma bone disease. Now, to treat bisphosphonates is what we use to strengthen the bone, okay, in patient who has got multiple myeloma. I showed you this picture earlier on. The bone is not a static structure. There's always a remodeling process going on. Old bones, especially old bone, being dissolved by the osteoclast, new bone being laid down by the osteoblast, two different cells. And the role of this biphosphonate is given IV, and it binds to the bone itself, and it stays there for a long, long time, some years, So it stays there, and it inhibits the action of this cell that break down the bone, osteoclast. All right, so it affects the resorption process. It allows the osteoblast carry on working, and that's how it strengthens the bone. So normally we give all our myeloma patients this group of medicine through intravenous injection. As for smoldering myeloma patient, the latest development is now with scanning, we can predict more accurately which patient is going to progress, and we will treat them with, the recommendation to treat them with this biphosphonate as well. Whereas for low-risk patients who the risk of development to progression to myeloma is not that high, we will treat them as though they have got osteoporosis. That is to lower dose of less frequent use of biphosphonate, or even just oral medication, oral biphosphonate. An MGUS patient, which is an early stage, just patient who has just developed a few cells and produced some antibody. We will do with the recommendation is to see whether they got osteoporosis or not. If they have osteoporosis, we treat them as such. And the difference between osteoporosis and using biphosphonate in osteoporosis and patients with myeloma is oral and injection form. And in my practice, I've come across patients who've been treated for osteoporosis with oral bisphosphonate, and I thought, okay, they're already on treatment, they carry on. But my impression is they get further skeletal event as a disease during treatment. So I do not think oral medication is sufficient for the strengthening the bone in myeloma. They need really something more stronger, like intravenously, like pamidronate or Zomita. So when to start treatment, as soon as the diagnosis is made, and we give it every time patient come in for a new cycle of treatment. There's every 4 weeks or so, and normally we treat for 2 years. And after that, if the patient's myeloma is in remission, we will stop. If the patient's myeloma is not in remission, we will carry on. Now, another medicine which has come to market, I think approved early last year, was denosumab, which is given subcutaneously, and is a monoclonal antibody which bind to the receptor called RANK. All right. So this RANK pathway, RANKL pathway, and in multiple myeloma, the interaction between the bone marrow stroma cells and abnormal cancerous plasma cells involve a lot of receptor and what we call ligands, block interaction between communication between those two cells, leading to the proliferation of these plasma cells. And one of them is RANK, and by blocking this RANK, it will also lead to inhibition of this osteoclast action and allow more osteoblasts to act, thereby protecting the bone. The initial trials long time ago was done on, they used this medicine for all tumor. But a small number of plasma myeloma patients, there was some concern about it affect the survivor, it may compromise survivor. So a completely new trial was conducted, and a report came out last year show that it's not inferior to zonidronic acid. But a few more patients got low blood calcium, and some patients also get complication, what we call osteonecrosis of the jaw. And compare this to biphosphonate, because biphosphonate bind to the bone itself, and it lasts for a long time, for years. And the effect of this denosumab will probably last for 6 months or so. So this to bear in mind when we decided to use this medicine. So far, I have not put my patient on this medication. So what are the possible side effects of this group of medicine? And when we start patient on this treatment, a lot of them, the blood calcium level will go down low. Quite likely it's because the bone, the osteoblast start laying down the bone matrix, and the bone become mineralized. The calcium go from the blood back into the bone itself. That's most likely explanation of the low calcium in the blood on starting this sort of treatment. And the other potential side effects is osteonecrosis of the jaw. And this osteonecrosis means the osteo means bone, in French or whatever European language. The bone dead. Necrosis means dead. Jawbone become dead. It can occur, when they occur, typically occur if the patient on treatment and they go for dental extraction and procedure involving the bone. And the bones become, surrounding the traumatized area become dead, and it become getting larger and larger a bit. And it will not heal for a long, long time, and it may keep on discharging pus. And sometimes this pus may drain out from externally on the gum, or even worse, through the face. And also sometimes pieces of small bone may come out from the mouth, from the wound area. So this can be very bad. This side effect can be quite difficult to treat. The other complication that can arise is atypical fracture of the long bone. Myeloma itself already, they have lytic lesion in the bone. They're more likely to fracture. But this fracture is different because you can see the picture there here. There's no lytic lesion, but the outside, on the surface of the bone, it looks like it's a bit thickened like that. and this area are actually weaker, and they can fracture, and patient can experience pain there for a long time, and it can occur on both sides, like on the femur there, both sides, patient feel pain on both sides. And then the fracture is different also because the fracture tend to break straight across, it's rather than like spiral shaped crack like that. So these are the some complications that can occur with biphosphonate, and we normally will advise patients to cut down on these side effects. We ask patients to take calcium, and usually with vitamin D. If the blood calcium is not high, all right, routine to take calcium vitamin D supplement. And we advise patients to report any unusual pain in the thighs, hips, or groin. And if patients is going for any dental procedure, they should stop this medication for at least 3 months. We always be concerned when patient has some dental problem, and quite often we refer patient to dentist before starting this sort of treatment. Although most of the time we just ask the patient, have a look into the mouth, no problem, then we carry on. But some doctor will refer to the dentist first before starting on this treatment. Now, orthopedic surgery, orthopedic surgeon has a lot to offer. Sometimes when we see patients whose lytic lesion is so big, so large on their multiple, we know the bone is already very weak, and before they fracture, we better ask the orthopedic surgeon come along. Sometimes they assess and feel, well, it's worth doing some procedure to prevent a fracture by putting in a nail within the bone. So that is done in a preventive manner before fracture occur. An orthopedic surgeon, of course, when the fracture occur, they will come along to assess the patients regarding surgery, hip replacement, and as I mentioned earlier, they have various scoring systems to decide who is fit for surgery. Say if a patient is very elderly, already 80, 90 years old, risk of operation is very high. They may not offer surgery to repair, to fix the fracture. And orthopedic surgeons are also involved in compression of the spinal cord. And the picture below, you can see on the MRI scan, the myeloma form a mass pressing on the spinal cord. And these are emergency situations, all right? And there are different approach to this. We can also use radiation if sometimes radiation is often preferred because it's a lot less traumatic. But really, if the compression is so big, so severe, patient at risk of paralysis, they may well go in to do it straight away. And sometimes the vertebral column or any bone becomes so unstable, the orthopedic surgeon will go in, or spinal surgeon will go in to fix it, make it stabilize. And we have patients who went for transplant in our NUH. They have a surgery procedure to stabilize the vertebral column before they transplant. Now, this MRI scan showed, the femur on both sides, and there are a lot of disease on the bottom there. You can see the patient has a lot of pain in the knee and also in the lower part of the right thigh. And the MRI scan show a lot of infiltrations, and the orthopedic surgeon will come in and do the repair work. And the patient is able to walk again. Other orthopedic procedure is a bone augmentation procedure, and with this, the aim is to the main aim is really to treat the pain, and in some circumstances, perhaps restore the structure and posture of the patient. And in this procedure, balloon kyphoplasty, the patient will lie prone on the bed, and the surgeon will use the needle to go from the back here go right into the fractured vertebra, and they will create the tunnel with this specialized needle. And after that, after creating a channel there will be a bleeding from there. And then after that, they will introduce a catheter. At the tip of the catheter, there's an inflatable balloon. And then they will inflate, once they inserted this sort of catheter with a balloon, they will inflate the balloon. As they inflate the balloon, it will expand, and to some extent, the crushed area will expand again and restore the normal height of this vertebral body. And after they have done that, they have to adjust the patient, keep the patient in that posture, and then they will inject some bone cement in this cavity created. All right. Yeah. And usually only a small amount of bone cement needed, about 2 to 7 ml. And they have to be given at the right pressure. The orthopedic surgeon got to reconstitute this cement, inject it at the right pressure. Cannot be too forceful, otherwise it will leak out to a different area. And this balloon kyphoplasty, whereas vertebroplasty is just simply insert a needle into the fracture site and inject the cement, and no balloon involved. Now this cement produced by different companies. I black out the actual trade. Now how does it work? So the function of this cement is to stabilize the fracture site, and more importantly is to control the pain. So most of the time we refer patients for this procedure is for pain control. It's quite difficult to understand why should the pain control be so rapid. You just need to inject that in. Why the pain control? Why is that pain control? And it is thought that the heat generated, when you reconstitute this sort of product, it can be quite hot. So when you kind of inject this hot stuff in there, the heat generated actually destroy the plasma cells. The heat also, once you destroy the plasma cell, you affect all the chemical release by this plasma cell, thereby you get less pain. So often patients can get pain control the next 1-2 days and up and about already. Now the complication can occur with this sort of procedure, and as shown on the picture here, the top one, what happened? The cement leaked out from the front of the vertebra, and in the front of the vertebra they have a complex venous drainage, and what we concern is this sort of material enter the vein. Whereas the one at the bottom there, you can see there's a leakage of this cement backward along the track that we created. I told you earlier we need a track to put in the balloon catheter, and the cement leak backward, and also some leakage backward. The main concern is the cement leaking backward is it will press on the spinal cord and causing cord damage. And also the heat generated may also cause additional damage also. And not every patient is suitable for this condition. They have to be assessed by the orthopedic surgeon. If the fracture is far too advanced, or if there's still a lot of tumor mass, soft tumor mass, we cannot depend on this to stabilize the bone. The picture on the right side shows somehow, I got it somewhere, actually the actual cement itself can enter the bloodstream and enter into the lung, causing embolism. The other way to treat pain as well, that is with radiotherapy and chemotherapy. Actually, patient chemotherapy now we have a lot of modern regimen nowadays with 3 drugs combined. the disease control is very rapid. Within 1-2 cycle, within 2 months or so, patient's pain already feel a lot better. So whether we want to subject patient to procedure, this and that, often they become unnecessary. How about radiotherapy also can control pain. It's given normally in lowish dose. It's given to control pain, any impending pathological fracture. I told you earlier, spinal cord compression due to tumor, we can shine on that plasma cell mass to shrink it. Now the thing with radiation is the thinking is radiation, you kill the plasma cell, we also kill the good cells, the osteoblasts, this and that will affect wound healing, but it's not to be true, all right? In fact, radiation can cause a rim of sclerosis, that means enhanced bone deposition in the lytic lesion area. Quite often it causes some enhanced sclerosis and improved healing. Chemotherapy itself will not lead to the healing of this sort of lytic lesion, whereas radiotherapy can potentially improve, although may not be complete. My last few slides. Now these few slides show the PET scan. We use more and more modern technology to demonstrate disease where they are in the bone. And now we are applying this sort of thing in treating myeloma nowadays, and not just at the diagnosis stage. Now in a PET scan, you can see before the treatment. This is a picture before the treatment, PET CT scan, combine both. And there are a lot of, in the pelvic bone, there are a lot of deposition there. And after treatment, at the bottom picture, the blue one, you see all this light up area reduced, but there's some very intense reddish orange color area there still persists. And so the patient undergo after treatment, after transplant, all this what I meant, they are left with this intense area, and the patient undergo radiation to that localized area and lead to resolution of this area there. So the investigation for bone disease lead to using different radiological technique seems to have some impact on how we treat disease. In this instance, we used to monitor myeloma treatment with blood tests, monitor the antibody level, chemistry, kidney tests. But now it looks like in the future, we may also progress like treating myeloma a bit like solid tumor, like that. In that sense, the concept is slightly different. Just that not that biochemical disease, bone marrow fields detecting cells there. We also look at myeloma a bit like tumor-like in that sense. So that's my talk.